Hello, everyone. My name is Jennifer Nosker, and we are pleased that you could join us all for this lecture in our Volume 5 of our 12-week No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And we would like to thank our sponsors for their financial support for the series. And before we begin, we want everyone to know of our YouTube channel. Every No Neuropsychology and every No Neuroanatomy lecture is available for your viewing pleasure. Be sure to go check it out, subscribe, and like our lectures. Now, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website later this week. Now, it is my pleasure to introduce Dr. Licia Pacheco-Luna for today's lecture on fundamentals of neuroimaging approaches to cognitive impairment. Dr. Pacheco-Luna is currently a clinical instructor in neuroradiology at Johns Hopkins Hospital and will be joining faculty there as an assistant professor in radiology and neuroradiology in July this year. She has completed neuroradiology and PET-CT imaging fellowships at Johns Hopkins Hospital and a clinical neuroradiology fellowship at the Salpêtrière Hospital in Paris, France. And without further ado, Dr. Pacheco-Luna will begin her presentation.
I believe you're on mute.
Sorry. Good afternoon, everyone. Thank you all for being here. It's very exciting to be part of this, and thank you, Emily and Jennifer, for the invitation to share some of our experiences here. All right, so today I'm going to give you an overview and discuss how neuroimaging can help in the identification differential diagnosis of a patient coming with cognitive complaints. This is not a lecture on specific imaging methods and techniques, but rather a more practical approach as to how we radiologists deal with those patients. So today we'll learn what is the overall imaging approach of patients with cognitive decline, what are the specific indications for imaging and basic MRI protocol we use. Then we'll go over the more specific imaging findings that we may encounter. And finally, I'll show you a couple of practical dementia cases that exemplify the routine in the PET clinic. So first of all, why should we image these patients? So the more routine use of neuroimaging in patients with dementia is actually controversial. There are many published guidelines on the clinical evaluation of dementia. And they do not recommend, imaging studies on a routine basis. But they do include clinical prediction rules to identify patients who might have reversible causes of dementia that can be diagnosed with imaging, for example, pseudohematoma, normal pressure hydrocephalus, treatable cancer, etc. The prediction rules vary, of course, including factors such as young age, for example, a patient with less than 6 years old, if a patient has focal signs, in short duration of symptoms, for example, less than 2 years, etc. So the problem is that the sensitivity and specificity of these prediction rules are obviously not very high. And, there are many medical societies that do recommend structural imaging with either a non-contrast CT or MRI in the routine initial evaluation of all patients with dementia. For example, the American Academy of Neurology and some European societies. The general practice is to order imaging when patients present with unusual or atypical findings, or when imaging findings may be reassuring for patients and family. Such differences in practice may be attributable to the context in which the patient is seen. For example, neurologists who may only see a person once, we usually obtain imaging when a patient referred from primary care, whereas a primary care clinician who has the advantage of serial observations of that patient over time, they are known to them, may order imaging studies more selectively. So some families will also request imaging studies for reassurance, which are requested after explanation of the limited yield of such studies. So what imaging should we use? In most cases, MRI is preferred over CT because it is obviously more sensitive for a broad range of potential pathologies. And non-contrast brain imaging is in general sufficient for the routine evaluation of patients with suspected neurodegenerative dementia. So what do we look for on imaging? Basically, we want to answer three questions. First, we want to rule out a treatable cause. Then we want to quantify the degree of white matter small vessel changes. And finally, we will search for an atrophy pattern that is suggestive of a neurodegenerative disorder that could support or question the clinical suspicion of a specific disease. So what protocol do we use? With 4 basic MRI sequences, we'll be able to assess and rule out virtually all structural causes of dementia. So with FLAIR, which is a fluid-sensitive sequence, with the suppression of CSF signal, we'll be able to give a good differential diagnosis of all sorts of diseases involving the gray and white matter. And especially, we will assess the degree of white matter microvascular changes, and we will go over that in detail shortly. We can use either T2, 2D, or as in our institution's protocol, 3D FLAIR, which is even better because it allows multiplanar reconstructions, particularly important in the setting because we want to look at the temporal lobes, preferably in a plane that is perpendicular to the long axis of the hippocampi. So as shown here, so we have one acquisition, this one, the 3D FLAIR, and then we can afterwards do the post-processing and do, and get the plane that we would like, which is not possible, of course, with the 2-dimensional FLAIR sequence. As of susceptibility weighted imaging, we can use either gradient echo that we call T2 star, the sequence here, or preferably the more sensitive SWI or susceptibility weighted imaging, and look for the chronic, actually, I have the pointer now, and look for the chronic microbleeds. So those are sequences that are very sensitive to hemosiderin deposition. So this is the T2 star and the SWI, which is, higher, has a much higher resolution than our regular T2 star sequences. And most importantly, we want to include a volumetric morphologic T1 imaging to evaluate atrophy. As with FLAIR, we will have coronal reconstructions on the long axis of the temporal lobes. So again, we have one acquisition on 3 volumetric one, and then afterwards we can reconstruct in any plane that we want, as shown here. So I have one sequence that was acquired in the sagittal plane, and then I reconstructed with along the long axis of the hippocampus, as demonstrated on this coronal plane. And at our institution, we also do a coronal observe, which stands for phase contrast inversion recovery, which allows for a better contrast to noise ratio than our regular T1 sequence. As you can see here in great detail, the gray matter differentiation as compared to our routine regular T1 imaging. And obviously, DWI or diffusion weighted imaging, which is essentially part of all of our protocols. This is a sequence that measures the random Brownian motion of water molecules within a voxel of tissue. And in general terms, highly cellular tissues or those with cellular swelling exhibit lower diffusion coefficients. And those will appear as bright on the sequence. So diffusion is particularly useful in tumor characterization in cerebral ischemia. So if we have a stroke, that will be bright in the sequence, okay? In the setting of dementia, though, a DWI is particularly key if the patient comes with rapidly progressive dementia, a cerebellar syndrome, including ataxia and nystagmus, visual changes or hallucinations, and myoclonus, in which case we're talking about CJD. So that we'll see asymmetric diffusion restriction involving the basal ganglia and cortices, as shown in this image here. So it's very subtle, but we do see some increased signal intensity in the head of caudate here on the right side, and also in parts of the cortex. So in this case, it's subtle, but this is very suggestive of CJD if a patient comes with those symptoms. And if eventually this patient undergoes an FDG PET-CT, we'll see that those areas of diffusion restriction will correlate with areas of decreased metabolism on PET. So the same regions that are abnormal on diffusion imaging, they are hypometabolic on the PET-CT, for example, in the left frontal region here. There's a very good correlation between those two sequences. So, okay, now we have our protocol, and with that, we hope to answer those 3 questions. The first one is, does the patient have a treatable cause of cognitive decline? So here we have a patient with a large extraxial mass with heterogeneous contrast enhancement, a mass effect upon the frontal brain, parenchyma, compatible with a meningioma, right? So those are slow-growing frontal compressing lesions that can cause behavioral and cognitive changes that are indistinguishable from clinically from behavioral forms of frontotemporal dementia or Alzheimer's disease. And that fortunately for the patient, it regresses after surgical management. So there's a very, very large mass that shows very strong contrast enhancement. So this is a T1 sequence post contrast, and we see some also this might be calcification of the T2 star. We cannot really tell between calcification and hemosiderin deposition, but we know that this tumor is usually calcified. So those are foci of calcification in the T2 star sequence. The lesion is shown here in this coronal T2 image, compressing the brain, and all this white T2 flare hyperintensity in the white matter is all edema of the parenchyma. All right. Another treatable cause of cognitive impairment is that incidentally found subdural hematoma that we see eventually. So interestingly, this was a recent patient with myocognitive impairment that came in for a pre-research study evaluation and was found to have this small subdural collection with some minimal mass effect upon the left frontoparietal parenchyma. And obviously, this patient was determined to be ineligible to participate in this Hopkins MCI myocognitive impairment research study. So he had to be excluded because his symptoms were probably because of this hematoma. Another common treatable cause of cognitive decline, as shown in this patient with moderate dilatation of the subanterior ventricles, that is somewhat out of proportion to the degree of so-called prominence seen in normal pressure hydrocephalus. So we'll also look for narrow sulci and subarachnoid spaces at the vertex as compared to the perisylvian fissure regions as seen here in this coronal plane. So when we see this pattern, this is very suggestive of NPH. So if you see on this coronal plane, the sulci on the vertex are narrowed as compared to the sulci around the sylvian fissures here at the bottom, and even in the temporal lobes. So when we have dilatation of the ventricles and that pattern of so-called effacement, this is suggestive of NPH if the patient have the symptoms. So I showed you the most common treatable causes of dementia, but this list, goes on and on, as demonstrated here in this table. Just keep in mind that any space occupying lesion or infectious process involving the brain or meninges can potentially manifest clinically with cognitive changes. So basically, we have to, keep in mind that any, space-occupying lesion in the brain can give you those symptoms. And then there are the structural but non-treatable causes of cognitive deficits. For example, sequela of prior trauma, with the more common involvement with encephalomalacia, gliosis of the frontotemporal lobe. So when you see this pattern, we see those regions of T2 flare. In this case, we're showing only flare, but T2 flare hyperintensities in the subcortical matter of the frontal regions, the temporal regions. And here we see that both temporal lobes are involved. And when we see this is very typical of a sequela of TBI. Advanced stages of multiple sclerosis, where we see diffuse brain atrophy advanced for patient's age and confluent white matter signal changes and multiple confluent black holes are shown over here. So this is also a very typical pattern. Those patients with long-standing severe multiple sclerosis, we see those patch areas of confluent hyperintensities involving the white matter, the periventricular and subcortical white matter. In those regions of lower signal intensity here is almost like the CSF, is really the destruction of the brain, and we call this black holes of multiple sclerosis. Also, sequela of prior infection, as in this case of a patient with AIDS dementia complex, or HIV-associated dementia, or HIV encephalitis, where we see diffuse brain atrophy and relatively symmetric bilateral white matter T2 flare hyperintensities. So this can also give patients dementia symptoms. All right, now we're gonna focus on the vascular etiologies of dementia, where the chronic small vessel disease is the most important player, being the most common cause of vascular dementia and cognitive impairment. As we all know, this is an age and vascular risk factor related process, and we see predominantly periventricular multiple white matter lesions, sometimes confluent with relative preservation of the subcortical white matter, although we may see subcortical white matter involvement. It is in a lesser degree as compared to the periventricular. So people have mapped the common regions of chronic white matter microangiopathy as shown over here. In anything that does not follow the distribution should evoke alternative diagnosis. So when we see, this is everyday practice. We see this all the time, this foci of T2 flare hyperintensities involving the periventricular white matter, sometimes cortical white matter, but it's mostly in the periventricular regions as shown in this slice here. And this is the usual distribution of the microvascular ischemic changes. It is important to quantify the degree of white matter disease. There is this Aphasias scale, which is used simply to quantify the amount of white matter T2 hyperintense lesions that are usually attributed to chronic small vessel ischemia. So this classification was proposed by Aphasias and Schmidt in 1987, and it remains the most widely used system for describing white matter disease severity in publications. It is not generally used in clinical practice in the US, although it is very popular in other countries. So here in the US, terms such as mild, moderate, and severe are favored to describe the Aphasias 1, which is the mild, where we just see a few scattered foci is in this left image. And the moderate, or Aphasias 2, where we see just, like beginning confluent lesions, as in this image here, and Aphasias 3 are severe, where we see the advanced stage with large confluent areas of periventricular white matter involvement. So when we see this severe white matter microvascular disease, vascular dementia should be considered in the differential diagnosis to explain patients' cognitive symptoms. So it's very common that we see, patients coming with dementia and they just have, just severe white matter involvement by microvascular ischemic changes. And this is just why this patient has dementia. So this is just vascular dementia. Then we look for the presence and distribution of small chronic infarctions and lacunes. So lacunes are those holes measuring up to 1.5 centimeter in the brain and are associated with cognitive dysfunction and a higher risk of future stroke. There's this term Bieswanger disease, which has actually fallen in popularity, and I don't know if you have ever heard of. This is better known as a subcortical atherosclerotic encephalopathy. It describes an exclusively white matter vascular dementia, which refers to this progressive clinical syndrome of cognitive impairment and compatible imaging features seen over here, meaning relatively symmetric and diffuse bilateral deep periventricular white matter lesions and multiple small chronic infarcts in the basal ganglia, thalami, and pons. So this is your typical Bieswanger disease. So usually those patients have vascular dementia. Another feature of chronic small vessel disease are the microbleeds in the central brain or basal ganglia, usually attributed to poorly controlled systemic hypertension. So also a very common, finding in our routine of those foci of signal loss in this susceptibility weighted imaging that I mentioned before. So it's very sensitive to hemosiderin deposition. So those are microbleeds, and when they are, located in the central brain, this is very suggestive of chronic hypertension. Sequela of prior vascular insult, especially when it involves the bilateral thalami and frontal periventricular regions, may also be responsible for cognitive deficits. Here we see a large area of encephalomalacia and gliosis in hemosiderin staining in the right basal ganglia and thalamus as a sequela of prior hypertensive hemorrhagic stroke, as shown on this CT here, which is what was the first imaging when the patient got to the hospital. So now we just see a hole in the brain, encephalomalacia, surrounded by this halo of signal drop, which is hemosiderin, it's just old hemorrhage. So my last example in the vascular category is cerebral amyloid angiopathy. It is increasingly recognized as a major contributor of Alzheimer's disease pathogenesis, and often those two coexist. Okay, so here we see multiple microbleeds in a relatively peripheric distribution, as opposed to the central involvement of hypertensive microhemorrhages that we just saw in the other case. Although sometimes the distinction is difficult because they, as I said, they coexist. Also distinctive features are the superficial hemosiderosis and sequela of or ongoing lobar hematomas, as shown in this image here. So patient has this staining signal drop hemosiderin deposition, basically along the cell side and subarachnoid spaces at multiple parts of the brain. So multiple parts of the brain is also like old hemorrhages here in the left caudate head, in hematomas of different ages. So you see this hematoma is different in appearance from this one. This one is older, has more hemosiderin deposition, and all this taken together is suggestive of amyloid angiopathy on imaging. All right, now switching gears to the, I think, fun part of this lecture, which is the atrophy pattern recognition, and maybe the most difficult one too. So, so this is based on the idea that the atrophy pattern follows the distribution of lesions on histology. Schematic of the BRAC and BRAC extracellular amyloid and neurofibrillary tangles or tau stages during the progression of Alzheimer's disease. Here, in mild in blue, moderate in green, and severe in red correspond to the density of amyloid in tau deposition. So in typical cases of Alzheimer's disease, amyloid beta deposition precedes neurofibrillary and neuritic changes with an apparent origin in the frontal and temporal lobes, hippocampus, and limbic system, as shown in the top row. And the tau depositions start in the medial temporal lobes and hippocampus and progressively spread to other areas of the neocortex, as seen in the bottom row. So we can actually track those changes with PET-CT imaging. The atrophy pattern seen on MRI also follows the Brock and Brock progression of disease, as shown in these 3D maps here from multiple MRIs, illustrating the changing atrophy that progress from mild cognitive impairment to Alzheimer's disease, with atrophy limited to the hippocampus on the earlier stages of disease, and progressively evolving the temporal lobes and parietal and frontal association cortices. So this is mild, this is severe. So again, Alzheimer's disease is the result of two histological lesions, the deposition of cerebral amyloid beta and intracellular neurofibrillary tangles, or tau, and eventually progressive loss of neurons. And is the most common cerebral amyloid deposition disease. So those are the amyloid plaques, and those are the neurofibrillary tangles within the neuron. It is also the most common cause of degenerative dementia, responsible for 60 to 80% of all dementias, and therefore, imposing a significant burden on developed nations as the U.S. So the prevalence is strongly linked to age, with more than 1% of 6 to 64-year-old patients being diagnosed with the condition, compared to 20 to 40% of those over 85 to 90 years of age. This is most commonly sporadic, with rare genetic forms estimated in 1%, as opposed to the frontotemporal dementias that have frequently a genetic component, as we'll see next. One of the first described MR imaging features on AD, or Alzheimer's disease, described over decades ago, is the hippocampal atrophy. So the hippocampus is smaller in MCI, or myocognitive impairment, and AD as compared to normal age-matched controls, as shown here in this image. An old but still helpful described feature is that the speed of hippocampal atrophy is prominent in AD. Therefore, it is important to evaluate serial imaging and look for progression of atrophy over time. The degree of hippocampal atrophy correlates with memory performance and predicts conversion to from myocognitive impairment to AD. So this is just to show you, the differences of 75 years old. And you see, this is a normal control. We see a very good hippocampus, a good volume with no atrophy of the adjacent cell site. It is one you start to see some prominence of the choroid fissure in the adjacent ventricle here, and in this one with AD, those changes are much more prominent in a patient of the same age, 75 years old. So people have, come up with those atrophy scales. The most popular one is the MTA, or medial temporal atrophy scale, or Shelton scale. It is a visual score using coronal T1 weighted images in a plane parallel to the brainstem axis and through the hippocampus at the level of the anterior pons. This is more specific to radiology, and I apologize for that. It goes from 0, which is the normal, through 4 stages. The MTA1 is mild prominence of the choroid fissure. Choroid fissure is just is this fissure here just above the hippocampus. MTA2 is when we see prominence of the temporal horn of the lateral ventricle, as demonstrated here. So we see the adjacent temporal horn is dilated. The MTA3, we see moderate hippocampal atrophy, as shown over here. And the MTA4, we see severe hippocampal atrophy. So they say when a score equal or greater than 2 is abnormal in a patient younger than 75 years old, and abnormal if equal or greater than 3 in a patient of 75 years old or older. So this is just to show, this is very specific to radiology, but it's just to let you know that those things exist. The people, the clinicians want us to assess the degree of atrophy of the temporal lobes, and this is just one of the tools that we may use for that. In the recent years, with the advent of the automatic brain volumetric software, such as the NeuroQuant that we use here at this institution, the quantitative assessment of hippocampal and other structures atrophy is much easier now. NeuroQuant compares the MRI of a patient's brain to a database of healthy people of the same age, sex, and skull size. So, for example, here, this person's hippocampus normalized to the brain volume are below the 5th percentile as compared to the age max frontal. So it's much lower here as compared to the normal people. Okay, NeuroQuant can also more easily monitor changes in brain atrophy over time to determine how quickly an atrophy is progressing. So as I just told you a couple of slides, for us, it's important to see how fast this patient is progressing, how fast the atrophy is progressing over time. And this is just a tool that we can use to quantify that quantitatively. Okay. But there are just two problems with this. First, there's a large overlap between hippocampal volume of normal controls and AD patients. So there's no right single cutoff value for a pathologic hippocampal atrophy. Sometimes we have a normal person with no cognitive impairment that will have like a hippocampus that is, the same size of a patient with AD. So there's a large overlap over here. Second, the hippocampal atrophy is not specific for Alzheimer's disease. We can see it in many other entities, including frontotemporal dementia, Lewy body dementia, etc. When we look at the numbers for sensitivity and specificity of hippocampal atrophy for AD versus normal subjects, we see that those are pretty high at around 85%. However, this is not the question that the clinician asks, right? That is not the question that you guys ask us. You don't want to know if the patient has AD or nothing. The clinician wants to know if a patient has AD or something else, right? So when we look at the numbers again, comparing AD to subjects with cognitive complaints, this specificity drops significantly. So we need to look at the whole brain. So here we have a 71-year-old patient with diagnosed AD. We see relatively symmetric hippocampal atrophy with prominence of the choroid fissure and temporal horn of the lateral ventricles. So this is an MTA2. Remember, MTA2 in a patient younger than 75 years old is considered abnormal. Then we see medial parietal atrophy as demonstrated by prominence of the marginal sulcus, the marginal and parietal occipital sulci, giving sort of a posterior anterior gradient of atrophy, with greater atrophy in the parietal as compared to the frontal regions. So here we have more of a parietal prominent atrophy as compared to the frontal. This is better demonstrated here on the axial plane. So this is the parietal lobe. This is the central sulcus here. So everything posterior to that is the parietal lobe. And we compare the parietal, especially the left side with the right, we see that there's this predominant atrophy here. All right, this is just to demonstrate the same thing. All right, this is an older patient, 87-year-old person, also with clinically diagnosed AD, with a greater degree of hippocampal atrophy, in this case is in MTA3, but with relative non-dilated parietal sulci as compared to the previous case. So parietal atrophy is a feature of early onset AD, whereas hippocampal atrophy is seen in older patients. Okay, so here, different from the other patient, we see more of a temporal predominant atrophy. We see this, especially on the left side, the hippocampus is very atrophied with the dilatation of the temporal horn of the lateral ventricle with the choroid fissure dilatation. And as we compare with the other patients, we see that the middle parietal lobe is pretty preserved. So we see no pathologic, dilatation of the sulci. They look pretty good for a patient with 87 years old. So in older patients, the hippocampal atrophy is predominant over the parietal atrophy. Another example of an older patient with AD, again with moderate to severe hippocampal atrophy, but relative preservation of parietal regions. So this is just another example of the same thing. So temporal predominant atrophy as compared to the parietal atrophy. On the other hand, this is a much younger 56-year-old patient with early onset AD, where we see nearly normal hippocampi, but relatively prominent medial parietal sulci, including the marginal ramus of the cingulate sulcus and parietal occipital sulcus. So again, this is the marginal ramus of the cingulate sulcus. This is the cingulate sulcus over here. When it goes up like this is called the marginal ramus of the cingulate sulcus, and this is parietal occipital sulcus that separates the parietal lobe from the occipital lobe. And we see that those are prominent as compared to the frontal region. So this, again, a posterior anterior gradient. And again, this is more suggestive of, early onset AD rather than in older patients with AD. So medial parietal atrophy in younger patients. So again, here, people have tried to create scales to quantify medial parietal atrophy, ranging from grade 0 or no cortical atrophy, grades 1 and 2, which are mild and substantial widening of the posterior cingulate and parietal occipital sulci, and grade 3, where we have extreme atrophy of the medial parietal region with the described knife blade appearance of the cortex, as demonstrated over here. So we see this very, very prominent, this very severe atrophy of this sulcus in this blade, knife blade appearance of atrophy. And finally, although uncommon, remember the MRI can be normal in Alzheimer's disease. All right, so I'm just gonna have to speed up a little bit here. So frontotemporal lobar degeneration, this is common. This is the second cause of degenerative dementia after Alzheimer's disease. Typically, FTLDs occur in younger patients than Alzheimer's disease, usually with early onset, 40 to 60 years old of age and 60%, and 10% being diagnosed, with less than 45 years old. There is variable proteinaceous inclusions. There is this, the tau, the misfolded the tau protein. There is this TDP, which stands for transactive response DNA binding protein 43. And the FUS, FUS, which stands for fusing sarcoma protein, which is rare. There are no definite CSF biomarkers as we have for Alzheimer's disease. And the majority of cases are sporadic. However, 20 to 40% may relate to an autosomal gene. So just a word about terminology, because this gets confusing sometimes. Frontotemporal lobar degeneration or FTLD is the pathological description of a group of neurodegenerative disorders characterized by focal atrophy of the frontal and or temporal cortices. Okay, so these result in variable clinical manifestations known as frontotemporal dementia syndromes. Okay, so the term FTD or frontotemporal dementia should be used to denote the clinical syndrome caused by FTLD, which stands for frontotemporal lobar degeneration, and should then be followed by the phenotypic variant, behavioral, language, etc., as we'll see in the following slides. Older terms, such as PIC disease, should be probably avoided, especially when discussing the clinical presentation. Rather, it should be reserved for pathological entity characterized by PIC bodies, which is a form of tauopathy. I stress this because until today, many people still use the PIC, this PIC disease, and this term should be avoided as a clinical manifestation. It's more as of a pathological entity. The conditions grouped under the FTLD term vary from publication to publication, depending on whether clinical, pathological, or genetic factors are used in the classification and when they are published. So the most common used and convenient division based on clinical presentation is into behavior and language variants, or primary progressive aphasias, or PPAs. The behavioral variant demonstrates predominantly frontal lobe changes, whereas PPAs have a predilection for the temporal lobe, particularly the left, and is further subdivided into 3 clinical distinct entities: the non-fluent, the semantic, and the logopenic variants. Okay, I'll just skip this. So this is a 71-year-old male with behavioral changes, and here we see marked asymmetry, asymmetric bilateral frontal lobe atrophy, right bit on the left, as well as moderate bilateral temporal lobe atrophy, giving a right to left, and anterior posterior atrophy gradients, which is a typical pattern of the behavioral variant FTD. So just to show you that this is a bit different from what we saw with Alzheimer's disease, right? We have more of a frontal predominant atrophy as compared to the temporal predominant Alzheimer's disease. All right. Another patient, younger, a 57-year-old female with behavioral FTD, again demonstrating bilateral asymmetric frontotemporal atrophy, right on the left. And so you see that this is a bit the inverse from what we see on AD, as I said, where the gradient again is posterior anterior and more symmetrical than in FTD. So in FTD, it's more anterior to posterior and more asymmetric. All right. So although we learned that behavioral FTD involves more predominantly the frontal lobes, remember that it also involves the temporal lobes, right? And sometimes they can be marked or even worse than the frontal atrophy, usually on the right side. So to differentiate from Alzheimer's disease, we look at the lateral temporal lobe. While in AD, we see predominant atrophy of the mesotemporal lobe, the FTD will affect the temporal lobe as a whole, okay? So look here at the marked atrophy of the lateral temporal lobe in FTD as compared to AD, which is shown here. So AD, we see more of a hippocampal atrophy, and FTD it involves the whole temporal lobe. Right. So as I was saying, genetic forms are frequent. There are numerous genetic mutations that have been identified that usually correlate with both phenotypic and biochemical variants. All right, just skip that. Some of these genetic forms have imaging phenotypes. For example, a mutation of this gene called CNRF72 is associated with more of a generalized bilateral atrophy. This is, for example, a 51-year-old female, a patient that came in with clinical suspicion for behavioral variant FTD versus atypical Alzheimer's disease. And this patient had a family history of dementia. And we see this diffuse, relatively symmetric brain atrophy on MRI involving the frontal, parietal, and in lesser extent, the temporal lobes. And we had also for this patient a PET CT that showed some patchy hypometabolism in the left more than right frontal and anterior temporal lobes, resembling the FTD pattern. Okay, this is just another gene mutation, the GRN, which is, has also this imaging characteristics. They're somewhat specific, but not consistent, but suggestive. When we see this, it's suggestive of this genetic mutation. We can see this marked frontal and temporal and parietal lobes atrophy associated with Y-matter T2 flare hyperintensity. So this is more of a leucopathy, that can be also seen in these sporadic forms. But when we see this, we should raise the suspicion for GRN mutation. This is just another examples for the literature. There's also the VCP mutation. I'm just going to skip for the sake of time. And okay, I'm going to skip this one. And all right, so the primary progressive aphasias, so those are neurodegenerative disorders with predominant language abnormalities or language variant FTD. These come in three flavors or variants: the semantic dementia, the logopenic progressive aphasia, and the non-fluent progressive aphasia. The pattern of atrophy in semantic dementia is relatively characteristic and helps us distinguish these patients from those of Alzheimer's disease. And although there is considerable overlap with other primary progressive aphasias, we see asymmetric temporal lobe atrophy left more than right, as shown over here. So it is important to note that although semantic dementia is one of the so-called frontotemporal dementias, frontal atrophy is not really a notable feature, at least not early on the disease. The logopenic variant is more difficult to see on imaging, and again, there is a considerable overlap with other FTD subtypes. There is predominantly left posterior temporal lobe, perisylvian, and parietal atrophy on MRI, but you see also some degree of anterior temporal atrophy. So logopenic dementia is considered also a variant of Alzheimer's disease, given that usually these patients have positive, Alzheimer's disease CSF biomarkers and are amyloid PET positive. And progressive non-fluent aphasia, this is the last. This one is even more challenging to diagnose. Atrophy is variable, but generally most marked in the posterior frontal, insular cortex, and temporal lobe. Generally, the left hemisphere is also involved, although this is not universally the case. Okay, so this is just here for comparison. We have again the two patients with logopenic and progressive non-fluent aphasia. These findings are subtle, but with the appropriate clinical background can be supportive. So on the top row is the logopenic variant, where we see more of a parietal and insular atrophy, whereas in the non-fluent aphasia on the bottom row, we see more of a posterior frontal atrophy. Okay, so more on the posterior frontal atrophy, and this is more of an insular atrophy. All right, so take-home messages for MRI. We've learned our basic protocol and now how to rule out a treatable cause, quantify the vascular changes that could support a vascular dementia diagnosis. And we've learned the different atrophy patterns that may support or not, a given clinical suspicion. Our description of the atrophy pattern will answer the clinician's question. So it is important to us to have a good clinical information at the time of the reporting. We know that the hippocampal atrophy is not specific for Alzheimer's disease. We can see it in other disorders such as behavioral FTD and semantic PP. And on Alzheimer's disease, we have relatively symmetric hippocampal and medial parietal atrophy. In behavioral FTD, we see more of a asymmetric anterior frontal temporal atrophy. We've learned that the most common subtypes of FTD are the behavioral and genetic forms. And in some cases of genetic FTD, there are imaging features that help, as in the GRN mutation, where we see prominent white matter changes. In the semantic dementia, there is left but on the right anterior temporal atrophy. In the progressive non-fluent aphasia, we see also left predominant frontal insular atrophy. If finally, there is a large overlap between AD and logopenic FTD, and it may be considered in Alzheimer's disease subtype depending on the literature. So there's a large overlap between those two. Just because of the sake of the time, I'm going to skip the PET portion of this, and then I really apologize. So I would like to thank the ADNI and FT databases from where I use most of the images shown here, and the French Societies of Radiology and Neuroradiology, by which contents I was inspired when doing this lecture. And thank you very much. Thanks for your attention, and I'm happy to answer any questions if we have time.
Thank you so much. That was such a wonderful presentation. And we do have some questions. We'll ask a couple of first real detailed questions and then followed by some general questions. So first, in terms of the different rating scales that are used by neuroradiologists, are there rating scales for gradation of atrophy for PPA, specifically for PPA disorders, or is it primarily for general cortical atrophy in the hippocampus?
Yeah, that's a great question. Actually, just to start, PPAs are not very easy to diagnose on structural imaging, to be honest. So we really need to have this very strong clinical correlation, and sometimes we have to be like in touch with the clinician to see what they're looking for and what they really want us to report. So it's not, no, the short answer is no, we don't have any skills for that, and we wish we had, but it's actually very, as you saw, those findings are very subtle, and if we don't look for it specifically, we're not going to see it. So it's, yeah, there's no scale for that, no, unfortunately.
That makes a lot of sense, but yes, we were curious. So thank you for asking that question. And is there a preference for rating scales, particularly for hippocampal atrophy? Some of our neuropsychologists here have seen different ratings on neuroradiologist reports. So is there a preference or a rhyme or reason for different grading systems?
Yeah. So for some reason, those are not, the ones I showed you are not very popular in the US. I know they are in other places where I've trained. But here it's, we do use a lot NeuroQuant, which is this, quantitative assessment, which is very good, it's automatic. We just have a report and just have to read those numbers out in our report. But we just use the scales if we are requested to, actually. So we know there are clinicians that want us to report, and we do. But in general, like general practice is not using any scale. At least that's our experience here. I'm sorry. Yeah.
Okay, excellent. Well, thank you. And this is a little bit more of a general question. And the attendee wanted to know, what role and to what extent does neuroimaging play in both the clinical and research responsibilities of a neuropsychologist? And also in your position as well, I think would be helpful to know.
I'm sorry, can you repeat the question?
Yes. So the question is, what role and to what extent does neuroimaging play in both the clinical and research responsibilities of a neuropsychologist?
It depends on what the neuropsychologist wants, what he is looking for. Like in general, I mean, neuroimaging is everywhere, right? Like with all aspects of the neuroscience. So with, doesn't matter if it's those are neurologists or neuropsychologists. If they're interested in evaluating the brain morphology, that's where we play a role. So basically, radiology, is to describe the brain morphology. We're just describing what we see. And if there is a pathology that we can see, it's going to be in our report. In terms of research, then of course that's another issue. Research, like we have, all sorts of metabolic and functional imaging that we use in the research realm. We can use, functional MRI, PET-CT imaging. There's, many tracers available that are used in the research setting for, diagnosing Alzheimer's disease, frontotemporal dementia, even psychiatric diseases. We're starting to, also to play a role in that. So, I mean, as of now, neuroradiologists were just describing what we see morphologically, as I showed you in this lecture. So we want to rule out, pathologies that we can see, like there are, affecting the brain and giving those symptoms that would otherwise, be, caused by those lesions that we try to rule out. So yeah, I mean, short answer is the radiology plays a role in just detecting, morphologic alterations, abnormalities in the brain.
Excellent. Thank you so much for answering that question. And we do have a couple more. So one of the questions was, they were asking about posterior cortical atrophy and how that pattern might appear on imaging.
So that's a very good question, and I think that's better seen on PET-CT than on MRI. That we see this atrophy of the parietal region. We do see it pretty well on the PET-CT, and I wish I had a case to show you here. But MRI doesn't play a role like as important role as the PET-CT does in that regard. Yeah, I would say PET-CT is better.
Thank you. And another question is, does SPECT or PET add anything to the neuroimaging identification of an underlying pathology?
Oh, yes. The PET is PET more than SPECT, I would say. I think with the advent of PET, SPECT has fallen to use basically. So PET is so wonderful, I think, to diagnose or to help the clinicians. We see very well, I would say, Alzheimer's disease and certain types of frontotemporal dementias that it's just there's no place for SPECT anymore. We do have like a few requests of SPECT for that, but it's usually when the patient can't afford the PET-CT imaging. So it's really a second role. But PET clinic, the PET is really the first choice for especially in differentiating between Alzheimer's disease and frontotemporal dementia. Okay, so this is the FDA approved indication for PET-CT imaging in patients coming with dementia. So I would say 80% of the PET clinic is to answer that question.
Well, thank you so much. And really the last question, I think so far, is in terms of MEG, is this a form of imaging that you're using now, and has that changed anything in terms of understanding underlying pathology?
MEG, you said? Sorry.
Yes, MEG.
We don't know. MEG is more of a, I think the neurology uses more, we don't use MEG in the radiology. Is something that is not part of my practice at all.
All right, well, thank you so much. And it looks like, again, we have one more question. This individual attendee wanted to know, do you have any recommendations for report wording to support insurance coverage for PET or SPECT? Sounds like there's maybe some issues with insurance not covering these scans.
Yeah, absolutely. And I don't think that's something that we can say unless there is a request maybe from the treating clinician, the provider. We usually, because we're just rating these scans, like they're already being done. So we're at the end of the line there, right? So the neurologist, usually the neurologist or psychiatrist or psychologist, whoever wants that study, will put usually they have to explain to the insurance that this patient has, as I said, symptoms that are overlapping between Alzheimer's disease and other types of dementia, and that's usually why we image those patients. Okay, in terms of PET, structural imaging is another story. I mean, usually it's if the provider can prove to the insurance that this patient might have something underlying disease, tumor or anything underlying disease that can cause those. It's pretty, as I told, I think it was the first or second slide. It's pretty routine. It's a standard in those patients' care. So patient needs structural imaging to rule out treatable causes of dementia, basically.
Well, wonderful. And on behalf of No Neuropsychology and all the attendees, we would love to thank you for your wonderful presentation today. And again, for all the attendees, please join us next week on March 28th at 4 p.m. EST for Introduction to Lewy Body Dementia. Thank you so much.
Thanks for having me.